Hello and welcome to the second of the series of online education sessions brought to you by Salts Healthcare. If you have been unable to watch the first session where we explored caring for a neonate with a stoma, it's not too late. This episode, along with the other sessions, can be accessed via the Salts Healthcare website. In this second episode of Discover Series 2, Gail Fitzpatrick, lead nurse for Colorectal Services at Birmingham Children's Hospital, offers us an insight into how a baby or child should be sited pre-operatively for a stoma. She offers her rationale with regards to conducting this aspect of care and how it can greatly impact on post-operative management of the stoma in an extremely positive way. Gail has been in stoma care for over 40 years and was previously awarded the ASCN Stoma Care Nurse of the Year. Gail has been influential in the development of numerous paediatric pouches and patient information booklets. She is passionate about education, so has designed and implemented the Paediatric Stoma Care course in collaboration with the now Birmingham City University.
I'm going to explore the concept of siting babies and children for stoma formation. The ASCN Stoma Care National Guidelines Siting Standard Statement. Patients consented for stoma formation will have their stoma correctly sited by a registered nurse with a defined level of competency to perform this procedure. The benefits of stoma siting. A well-sited stoma can help the child and carer accept the stoma. Good stoma placement enhances the chances of the child and carer, their independence in stoma care. The ideal stoma site is one that is easily managed, allows secure adhesions of the appliance and gives freedom of movement. The consequences of poorly sited stoma is appliance leakage, inaccurate record of stoma output, inability to recycle the output, sore skin, appliance challenges, delayed discharge home, negative impact on the psychological, physical, and emotional health of the child and carer. In paediatric stoma formation, 80% of stomas are formed in the first 6 weeks of life. 10% are formed within 6 weeks and 2 years. The last 10% of stoma formation is between 2 years and 16 years. Most of the stomas formed in the first 2 groups are done as emergencies. Over 85% of paediatric stomas are temporary and not permanent. The most common stomas formed in the paediatric field are ileostomy, jejunostomy, colostomy, and then the continent stomas and ACE and Mitrofanov. So why is it that in paediatrics so few children and babies have their stomas sited? Is this because the stomas are formed as an emergency, that there's less paediatric stoma nurses and they are not based in the neonatal units? And both adult stoma care nurses and paediatric nurses and midwives do not feel competent and confident to site a baby or a child. So what is the solution? Training for paediatric surgical nurses, neonatal nurses, working in partnership with the surgeons and siting in theatre. Or the other option is exploring alternative siting methods. In neonates, the main issues of that the babies are very sick, very premature and tiny. Often they are moved to paediatric hospitals, unclear what surgery will be performed, and it will depend on the findings in theatre. So it is then difficult to know what type of stoma to site for when you really don't know what is happening to the baby's bowel. Or looking at siting options, possibly using a template in theatre. With the template, all that you need to do is have a neonatal bag or a paediatric and use the base plate as the marker. And if you can place that over the baby's abdomen, then that is probably the best site that you could get. And then with infants, their main issues is that they have no waist, so that you have to site the stoma higher up the abdomen. They're on the go and trying to keep them still to be able to have a look to see where the best site would be. They are also constantly growing. So when you site, you have to think about that in 6 months' time, what their abdomen might look like. And then they have exploring hands and constantly pushing you away. And then in the older age group, the primary school and the young adults, you just need to follow the adult stoma guidelines. But with this age group, they can be very, very challenging because their demands of where they want the stoma siting can be quite difficult. And they're not always very practical. And then with small bowel transplants in the paediatric field, often the stomas are sited at the time of the pre-transplant assessment. And as you don't know when the possible donor would be made available, you cannot site the abdomen because the mark will fade. So that you can use the umbilicus as a guide and measure out scars and work out where the best site is for the ileostomy and then map it out on a piece of paper. And this can be kept in the notes, so when a transplant is made available, you can use the measurements from the guide. This is an example of a poorly sited stoma, bilateral ureterostomies, where they are sited far too low in the groin, and it would be extremely difficult to try and put bags on these two stomas. And then a well-sited stomas, firstly one of a small bowel transplant, and then the other one is a colostomy. In the paediatric field, we have congenital abnormalities that can be quite complex. And this is a complex siting of a conjoined twin, where one of them needed to have a stoma and had the stoma for 10 months before they were separated. They are now 16 years old, and one of them has still got her stoma in exactly the same place. So in the future, let's strive for babies and children to be offered the same gold standard as adults, to have their stoma sited pre-operatively.
Thank you for watching this session. I do hope you have enjoyed it and it has been able to offer you some further insight and facilitate various learning opportunities for us as stoma care nurses when caring for a child with a stoma. And that perhaps for those of you who care for paediatrics in your own clinical practice may consider siting pre-operatively if it's something that you don't do already. This episode is able to be viewed on demand at the Salts Healthcare website, so it can be stopped and replayed at your convenience, giving you the time to write notes or reflect on certain aspects of the session if required. If anyone has any follow-up questions, then please do email us at discover@salts.co.uk and also use the same email address to complete the evaluation form to receive your certificate of attendance. The next session in the Discover series is being launched on Tuesday the 4th of May. In this session, Alison Kennedy will re-examine some of the paediatric conditions that can lead to stoma formation, and Liz Scudamore explores the specific needs of a child with a stoma when starting school. Thank you again for watching, and we look forward to seeing you next time.